Welcome, everyone. My name is Samir Kakodkar. I'm a gastroenterologist and specialist in ulcerative colitis and Crohn's disease. Welcome to Against the Grain. Please do check out the rest of my podcasts, which can be found at the website samir3.podomatic.com. It can also be found on YouTube or Spotify by searching my first and last name. For those who are interested in contacting me regarding questions or for virtual appointments, my email is samir3@gmail.com. Please join the private Facebook group called Against the Grain for ongoing discussions about these podcasts. This podcast is not meant to be medical advice or a substitute for medical care. This is a discussion to encourage further research into this topic. Thank you. Today we have Shriram, who I consider, probably one of the best GI pathologists I've ever encountered. So Shriram, thank you so much for taking time on a Saturday to go over IBD pathology with us.
Sure. It's my pleasure, and I want to say hello to all your listeners, and thank you for having me on your podcast.
Sure. Actually, I don't know if you remember, part of the reason that I have such respect for your skill and the way you read slides is, I back in 2008 when I was diagnosed with IBD, my brother was a fellow at Rush in cardiology, and I was a medical student at the time. And this, from my colonoscopy, the slides were read by the initial pathologist as kind of indeterminate or non-specific inflammation. And then, and it was like not diagnostic of IBD. And then I sent the slides to a couple different places, initially to University of Chicago. A few people tried to read it there, and they said, more consistent with ulcerative colitis. And then I actually came to your office as a medical student back then with my brother, and you looked over the slides with us, and you confidently said it was Crohn's disease. And eventually, on subsequent colonoscopies for me, it did end up being Crohn's disease. So I was, very impressed back then that you were able to call it when it seemed like nobody else could. So I don't know if you remember that from back then, but...
I don't remember, but it's a great story.
Yeah. Okay. So can you tell us a bit about your background and really how you got so skilled at what you do?
Sure. I'm a pathologist and with special interest in GI and liver pathology, but first and foremost, I'm a student. I love to learn more and more clinical gastroenterology and hepatology. And my best teachers are actually my clinical colleagues who I interact with, because I get a lot of feedback and information from them. I also review all the endoscopies before I look at the biopsies. So I'm a frustrated clinician actually who has become a pathologist. Mm-hmm. Also, I feel that my biggest teachers are actually the patients. Of course, they don't know that, but they provide me with these tissue samples that are so amazing, and I get to learn pathology better by correlating with their clinical profile, other laboratory data, etc. So that is my kind of a style. And I try to incorporate these aspects of the diagnosis within my reporting. Because if you just look at the morphology without the context, it is really very basic and non-specific. But in the light of all the findings, otherwise clinically apparent, it becomes far more accurate and interesting, and it's very helpful to the patient.
So, and you've recently retired, right? But how long have you been a pathologist and seeing slides from patients with colitis and Crohn's?
Sure. My journey in pathology started back back home in my home country, which is India, I did my pathology training at a very renowned place. It's called Postgraduate Institute of Medical Education and Research. It's located in the northern part of India in a city called Chandigarh. And after I finished my training there, I went to England. I spent 4 years in England and 2 years in Manchester initially. This was in a children's hospital. And then I moved to Leeds. And this was a wonderful coincidence because later I became a GI pathologist. And Leeds is famous throughout Europe as being the epicenter of gastroenterology and gastrointestinal surgery. For people who are interested in history of medicine, they may know a name, John Gallagher, and he's one of the very first authors of the surgical textbook of colorectal surgery. And he spent a lot of years in Leeds, and actually now Leeds has a very big center called John Gallagher Center of GI Diseases. In 1989, I moved here in Chicago, and lucky for me, I immediately got a job. Actually, I got residency position in Rush University Medical Center. At that time, it was called Rush Presbyterian St. Luke's Medical Center. And after I finished my 4 years of residency, even before I finished, I was offered a job there. And they had a need for gastrointestinal and liver pathologist. I didn't have fellowship training, but I did have these additional, residencies from 2 different countries and actually 2 different continents. So I had pretty sound background, and I didn't really need that much of training. So when I started my job as a GI and liver pathologist at Rush, and it has been almost 3 decades now, I found that talking to other pathologists was less useful to me than talking to the clinician. And so I found that interacting with clinicians, actually those days, the endoscopy wasn't electronic. So there were photographs, and I would go to the endoscopy suite to just look at some of the pictures, and then somehow download them on a floppy disk or whatever it was at that time, so that I got a clear idea of what the lesion looked like, because that really helped me in my assessment. And so I think the correlation part helped a lot. I retired about a year ago, but I still maintain a position, Emeritus Professor in my department at Rush. And I still teach residents and fellows, and I mentor them for their publications, etc.
Great. I think that is unique amongst not all pathologists, in my experience actually look at what the gastroenterologist is seeing on endoscopy, and your years of doing that, over 3 decades of actually seeing what the gastroenterologist sees, and then also incorporating that in your interpretation of the slides, I think is very, very valuable. So what are some of the misconceptions that gastroenterologists have regarding the pathology of IBD?
Well, I would say the misconceptions, there are quite a few, but they are on both sides. So I will start with the misconceptions that the gastroenterologists typically have. And, to start off, the first misconception I feel they have is the expectation that once they procure a biopsy or biopsies and provide it to the laboratory, the assessment will be quite good, meaning that they feel that the tissue is so diagnostic that a reasonably experienced pathologist will look at it and immediately figure out that this is IBD. Not just IBD, but this is a precise form of IBD, ulcerative colitis or Crohn's or whatever the situation is. And the reality is that, if the tissue does show features and quite consistently, but there is some overlap. There is also a lot of mimicry by other conditions. So unless you have a habit of correlating with the clinical profile, it is not going to be that accurate. So that is the first misconception. The second misconception, I would think, is the expectation that there is some uniformity between pathologists as to how they evaluate the tissue, how they interpret the tissue, how they format the report. And I feel that would be a reasonable expectation. But the reality is pathologists come in all shades. Some are very matter of fact. They have very short reports. Some are very descriptive. They describe a lot, but sometimes they don't interpret it and leave the interpretation to the clinicians. Some clinically correlate and communicate a lot with the gastroenterologist. So I think the gastroenterologists probably prefer the last type of pathologists. Another misconception I would think the gastroenterologists have is not recognizing or under-recognizing the value of very patient and good sampling. So what I mean by that is, let me give you an example. So we have maybe a limited form of ulcerative colitis, left-sided. And then as you go in, you find that the right side is all completely normal. And you go into the terminal ileum, and that is completely normal as well. So if a gastroenterologist just provides the left-sided involved tissue, this is somewhat incomplete because the pathologist would love to know what the right side was like. I know it looked normal, but is it microscopically just as normal? Or is it just less inflamed and it is looking less involved than the left side? And whether the TI is actually involved, because this will really help in the classification. So kind of not realizing the value of this good sampling. This is not done by all gastroenterologists, but some gastroenterologists do sample somewhat less optimally than the others. I can also tell you a lot of misconceptions that pathologists have. One of the misconceptions is writing a very descriptive report and expecting that it will somehow get translated into some form of interpretation that the gastroenterologist will automatically make. And it is best to spell it out rather than allow the gastroenterologist to have freedom in interpreting the way he or she wants to see it. It is better for pathologists to be clear about it. Also, I find that pathologists assume that gastroenterologists are familiar with the very, I won't call it a secret, but a pathologist lingo or a jargon, where they use terminology like, atypical cells, there is a nuclear polarity is different, there's hyperchromasia. All those descriptors are great. They are involved in making decisions for pathologists, but to expect that another physician from completely different field is going to be able to automatically interpret it is a misconception on the part of pathologists.
Hmm.
Also, some pathologists are somewhat hesitant in actively communicating. And I don't know what the basis of that is, because communication is always helpful and it's always safe for the patient, for the clinician, and for the pathologist. But communication is sometimes misinterpreted as being somehow lack of confidence in making pathological diagnosis. So those are some of the misconceptions that the pathologists have.
Sure. Yeah. A couple comments about that. The biopsying, I agree. I think for some GIs, I think most that are subspecialized in IBD, we do tend to do lots of biopsies and put in different bottles. But I think sometimes there's a reluctance to do that based on cost issues. That each subsequent bottle that you use, like if you're dividing the biopsy samples into cecum, right colon, transverse colon, left colon, rectum, it's more of a cost, which certainly sometimes needs to be taken into consideration. But I do think, at least on the index colonoscopy, when you're trying to figure out what's going on, try to make a diagnosis, it is very helpful to really know what's going on a histological level, even if the mucosa looks normal.
And that is quite understandable. That's one aspect of it, the cost, because every jar that you take is going to add to the cost. Also, the circumstances, because what we expect gastroenterologists to do may be different under the circumstances. The patient may be uncomfortable, the sedation level, the bleeding tendencies, or whatever else the clinical situation is. So, having a dialogue and a communication always helps both sides to understand each other's issues.
Mm-hmm. So you mentioned very appropriately that GI doctors, they don't intimately know necessarily the terminology that are in pathology reports. I mean, we kind of recognize the buzzwords that are associated with an IBD diagnosis, but as far as, I think probably most would not be able to actually point that out with confidence with actually looking at these slides. But we kind of have associative memory of certain buzzwords, and this is probably in line with IBD. So if you don't mind, I'd like to go over some of these buzzwords that I consider, probably in common with ulcerative colitis and Crohn's disease, and just kind of get your comments on what these actually are and their significance.
Sure.
So architectural distortion is one that we often see on reports, and it's something that we think of with IBD. So can you give us some more detailed info about what that actually is?
Sure. So, when you take biopsies, endoscopic biopsies, you're sampling primarily the mucosa. There's not much submucosal tissue sampled unless somebody deliberately tries to do that. So routinely what we get is the mucosa. And, the mucosa essentially has a few very important components. One is, of course, the luminal surface, and then the glands or the crypts that are interspersed pretty regularly within the mucosa. And then between the crypts or between the glands, there is connective tissue. And that connective tissue is generally physiologically occupied by inflammatory cells. That doesn't mean it's inflamed, but these are certain level of inflammatory cells, which is a composition of lymphocytes, plasma cells, macrophages, eosinophils. Neutrophils are generally not present in a physiological condition. So these inflammatory cells are in certain numbers, and this number, which is a physiologically normal number, is something that people have to learn in pathology by examining normal tissue quite extensively. So when you see a tissue from quote unquote colitis, what will happen is the chronic inflammatory cells, the inflammatory cells within the lamina propria, will multiply. And that is the first and foremost change that happens in IBD, in both the major diseases of IBD, Crohn's as well as ulcerative colitis. So it's not a selective increase in any one particular type of cell. It's basically a generalized increase in chronic inflammatory cells. So how do you differentiate this from normal population? And this is something which is a subjective assessment. So there is a maybe twofold, threefold, or more increase in chronic inflammatory cells in general, all types. And what this does to the skeletal network of the glands that are spaced in between these lamina propria cells is it makes the glands distort. They are no longer in a regular test tube fashion because they are overwhelmed by these population of chronic inflammatory cells. So there is some glandular disorganization. So I would say that crypt distortion or glandular disorganization is the immediate effect of having these increased chronic inflammatory cells in the lamina propria. Now, can it happen in other types of colitis? So generally, the extent of increase in inflammatory cells is less than what happens in IBD, at least in active IBD. And thus, as a result, the crypt disorganization is most commonly seen in IBD. It doesn't mean it's exclusively seen in IBD, but it is an effect of having greatly increased chronic inflammatory cells in the lamina propria.
And how long is it known how long chronic inflammation has to be ongoing to produce this finding? Like, is it on the order of weeks or months?
So generally, if we are talking about IBD, by definition, these are chronic diseases. Of course, when it starts initially, you're wondering just a few weeks, and when the diagnosis is established, we're talking about several months or sometimes several years. So it would take more than a few weeks to create this glandular distortion. So when you see the glandular distortion, many pathologists believe that that is a sign of quote-unquote chronicity. I would argue that the chronicity shouldn't be a definition that is done morphologically. It should be done chronologically by the duration of symptoms. However, I would say that in an acute phase, in the initial presentation of, let's say, ulcerative colitis, you may not see as much glandular distortion because that's a function of time.
Gotcha. Yeah, and that is a scenario that I've seen multiple times. Is I believe I have caught IBD very early in some patients, even to the point where they're symptomatic, but endoscopically things look pretty normal. And then the biopsies do show some signs of acute inflammation. So the diagnosis is a little bit unclear, but then later on it did evolve to, pretty soon after that, within perhaps a few months, actually developing the mucosal inflammation noted on colonoscopy. So what about the, cryptitis, crypt abscesses? This is another term that we often see with diagnosis of IBD.
Sure. So let's go through the sequence. So the first event was generalized increase in chronic inflammatory cells. The second event was the crypts got distorted, and they also get elevated from the muscularis mucosa underneath. So because there is just a significant increase in the chronic inflammatory cells, the crypts not only get distorted, they also get raised. The acute inflammation that is targeted towards the crypts, which is the cryptitis and crypt abscesses, this thing happens whenever there is a symptomatic flare. So when you have quite a severe episode of symptoms, so in other words, the activity level determines how the neutrophils come into play now, because the neutrophils are the third event happening, and they are basically targeting the crypts. And hopefully we'll talk about the differences between ulcerative colitis and Crohn's further into the discussion. Mm-hmm. But the neutrophils are the subsequent event and is more indicative of the level of inflammatory activity that you may see either symptomatically and or endoscopically.
Okay. And, what about these other, is that part of, there's a term basal plasmacytosis or basal lymphoplasmacytosis, meaning the immune cells, you actually travel down towards lower levels of the histology. At what stage does that occur, and what's the significance of that?
Actually, it is not so much as they are deliberately traveling in any one region. What it is you consider the lamina propria as the canvas, and imagine the glands being test tubes arranged along from the lumen going inwards, and most of the glands normally or physiologically go down all the way and rest very close to the muscularis mucosa. So in other words, the glands occupy almost the full length of the mucosa. But when the chronic inflammatory cells increase within the lamina propria, what that does is they increase in all directions. So they also increase in the little leeway that is present between the base of the crypt and the muscularis mucosa. So it is not as much as a special event. It is just a generalized phenomenon that occurs at the very beginning of IBD.
I see. Okay. And what about pyloric metaplasia? What is that?
Yeah. So what happens is, because the glands are the target of attack, and we'll talk more about this in ulcerative colitis. So because the glands are the target of inflammation, eventually there are adaptive changes similar to they are in other conditions where a certain cell type is the target. For example, in Barrett's, there is metaplasia because it's an adaptive phenomenon. Similarly, if you consider that ulcerative colitis is basically a disease of colonic glands, then to have some type of protection against the inflammatory target, the glands evolve into a different form that would be less prone to inflammatory attack. And one of the changes is having some form of metaplasia or alteration into its natural structure. So one of the common alterations is having a pyloric type or a gastric type metaplasia, which may be less prone to inflammatory insult. It may also be a Paneth cell metaplasia. So there may be different kinds of metaplasia. Metaplasias typically come into play after long-term continuous inflammatory injury. So metaplasias do not happen early in the disease. They happen quite late in the disease. And rather than crypt distortion, metaplasia of any type, pyloric or Paneth cell metaplasia, is a true finding of chronicity.
Okay. So, would you agree that those terms that I just mentioned are common or can be seen in both conditions, ulcerative colitis, Crohn's disease? They're not necessarily indicative of one or the other. Architectural distortion, basal lymphoplasmacytosis, cryptitis, cryptabscesses, pyloric metaplasia. You said Paneth cell metaplasia. Would you say all of those are in common with those two conditions?
There is a little caveat.
Okay.
The chronic inflammatory cells are common in both conditions, but Crohn's to me is a disease of a region, and ulcerative colitis is a disease of the glands. So anything to do with glands in general, whether we are talking about depletion of mucin, whether this generalized cryptitis, cryptabscesses, pyloric metaplasia, Paneth cell metaplasia, all the things that relate to the glands are far more common in ulcerative colitis than they are in Crohn's. They do occur in Crohn's, but they occur in a region. They occur only in a certain region that is inflamed. Away from the region, there are no changes like that.
Okay. So what are some other distinguishing features of Crohn's versus ulcerative colitis? Trying to find out definitively, if you can, what condition somebody has.
So there is a very interesting way of looking at what the target of the disease is. So let's deal with ulcerative colitis first. I think the ulcerative colitis is basically the only target is the colonic type glands. That's it. So hence you can then infer a lot of things that you typically see about ulcerative colitis, which is having just the mucosal injury because all the glands are located in the mucosa, not having any other part of the GI tract involved, because colonic glands are the glands of target, not the ileal glands, not the gastric glands. Then having no real radiographic changes because there are no transmural changes. There is no change in the wall. So externally, if you were to have a colectomy specimen and look at it from outside, it doesn't look anything abnormal, simply because the entire disease lies in the mucosa. To me, ulcerative colitis is a disease of colonic glands, and I call it like a horizontal disease because it goes all along the mucosal lining. Crohn's disease, on the other hand, is a disease of the region. Which region? A region that is around a lymphoid nodule. So I would call it a disease of perilymphoid area. Because the lymphoid nodules are rich in the TI or terminal ileum, hence there is a greater predilection of disease occurring in that area. Not only that, because the lymphoid nodules are not particularly located in one part of the wall. They may be located throughout the wall, between the mucosa and the submucosa, within the submucosa, on either side of the muscularis propria, the subserosa, etc. Hence, Crohn's disease is a transmural disease because it is the region that is affected, not just the target is not just the glands.
Gotcha. Okay, so I've heard that certain IBD specialists that speak at conferences talk about ulcerative colitis. Sometimes with long-standing disease, there is risk of bowel damage or colonic damage, and you can develop some degree of submucosal fibrosis with long-term ulcerative colitis. And that can lead to kind of these IBS chronic type symptoms if that develops. And it may not be true IBS, but the chronic inflammation leading to this submucosal fibrosis. Would you say that's something you've observed or accurate? And how does that happen?
That is possible, but it is quite unusual.
Okay.
It would have to be a very severe form of ulcerative colitis to begin with. In other words, the entire mucosal width needs to be affected so severely that you have exfoliation of the entire mucosa. Thus, you will have some granulation tissue in the upper submucosa, and a reaction to the granulation tissue may be some element of fibrosis. Those things are all possible, but they are quite rare in my experience. So ulcerative colitis remains fairly truthful to the mucosal injury. Can it occasionally cause submucosal injury? Sure, if there is denudation of the mucosa in a severe form of ulcerative colitis, whether it was at the initial episode or subsequently in a flare, you can then potentially have submucosal injury and some submucosal scarring. But the comparison between such a submucosal scarring with Crohn's would be quite a stretch, because Crohn's is a truly transmural disease. So when you talk about Crohn's, what happens is Crohn's is just as much mesenchymal disease as it is epithelial. So Crohn's is a dual disease. Ulcerative colitis is an epithelial disease. So when Crohn's affects the colon or the ileum or the stomach, as the case may be, what it does is the areas around the lymphoid nodules are affected. And Crohn's disease actually is always has a mucosal component. So it's not like there can be only a serosal component or just a muscular component and not a mucosal component. It is a truly transmural disease, but always has a mucosal component.
Okay.
And the mesenchymal reactive changes cause neural hyperplasia, ganglion cells increased, vascular proliferation, muscular thickening. It is very classical for Crohn's to have this thickened musculature. It may lead to stricturing. All the findings that you see described clinically, radiographically, grossly, and microscopically have all to do with the fact that Crohn's is a truly transmural disease. Also, the mucosal component of Crohn's is quite different from ulcerative colitis. So, mucosally, Crohn's actually has ulcers very often. So, this is a famous thing in the IBD world, that these two diseases are not properly named. There is a misnomer. Crohn's should have actually be called ulcerative enterocolitis, because Crohn's is the one that classically causes ulcers, whether they're shallow aphthous ulcers that are sitting atop a lymphoid nodule, or they may be fissuring ulcers. And so ulceration is actually more common in Crohn's disease than ulcerative colitis.
And for the people listening who are not or medically inclined, or patients, what we mean by transmural is all layers of the bowel being affected in Crohn's, and mucosally just the inside superficial layer in ulcerative colitis being involved. Now, you mentioned ulcerations. Occasionally we do see these deep ulcerations, and it's still called ulcerative colitis. And it's thought that can be a finding in severe ulcerative colitis to have deep ulcers. So what is the nature of these deep ulcers? Are they still just involving the mucosa, or are they going, I would assume that would be the case. So is the depth of the ulcer, is that not a reliable indicator as far as if it's going beyond the mucosa?
Yeah, so let's talk about the deep ulcers in both diseases. So we have potentially deep ulcers occurring in ulcerative colitis in a very severely active form of the disease. When you have an ulcerating ulcerative colitis, the ulcers are broad, they're serpiginous, they're hemorrhagic. They are different ulcers compared to the ulcers that you see, deep ulcers that you see in Crohn's. The deep ulcers that you see in Crohn's are fissuring. They are very deep, but the surrounding areas are edematous, and that's what leads to what is described as a cobblestoning. So these are fissuring, like penetrating ulcers, as if you have taken a blade and poked it into the lining of the bowel wall. And so these are the deep ulcers. They are quite different from the bigger and flatter and broader serpiginous ulcers that you may see in ulcerative colitis.
And moving on to granuloma, this is a distinguishing feature of often described between a Crohn's disease and ulcerative colitis being seen in Crohn's. Can you talk a little bit about what a granuloma is and what we should be keeping in mind regarding this finding?
Sure. So what is a granuloma? Granuloma is a discrete lesion. It is an identifiable, localized, discrete area that is seen microscopically. And it is basically a collection of macrophages or histiocytes that have altered their shape and form to any kind of antigenic stimulus. So in simple terms, it is a collection of altered histiocytes that is discrete, and it's visible or identifiable microscopically. Now that is a simple way of describing it. But granulomas can be in different shapes and sizes, and they have different nomenclatures. And we can talk a little bit about granulomas and Crohn's. So they are considered kind of diagnostic of Crohn's, but I want to give you some caveats here. One is the granulomas in Crohn's are firstly not that common. In the literature, they're described as being, anywhere from 20% to 60%. In practice, they're not seen that often. They're seen in maybe, I would say, upward, maybe 10 to 20%. They're seen more often in children, and they're peculiar type of granuloma. When you see a granuloma, I describe that as a Crohn's type granuloma because it is quite unique. So this particular granuloma that you may see in Crohn's has a smaller cluster of altered macrophages, and it is a small collection of epithelioid macrophages. These are paler, oval-shaped macrophages that are distinctly visible on histology. Now, they don't occur in all cases. In fact, I would urge most pathologists not to focus so much on granuloma and depend on the granuloma to make a definitive diagnosis of Crohn's, because then you will be missing a large majority of Crohn's diseases because you are waiting for the granuloma to show up on the tissue. It may never show up. Are granulomas more common in a certain phenotype of Crohn's? Perhaps, people describe the granuloma being more common in younger population with Crohn's and being somewhat more resistant to medications, but that is for the clinicians to correlate with. We do see granulomas sometimes, and they're wonderful when they are there, so the diagnosis of Crohn's becomes easier, but it's not the only thing that should make the diagnosis. Also, these granulomas are somewhat similar, I would say, to sarcoid type granulomas, except in sarcoidosis, the granulomas are several. There are several granulomas in one cluster. In Crohn's, there are very There are few and they are scattered around, and they are within the usual type of inflammation that is perilymphoid, maybe along with aphthous ulcers or a Fishring ulcer.
Okay. And you said the granuloma is somewhat specific, the Crohn's type granuloma for Crohn's. Occasionally we see granulomas associated with crypt rupture, and as you mentioned, cryptitis, cryptabscesses may be something more commonly seen in ulcerative colitis. So if you see a granuloma associated with some crypt injury, crypt rupture, my understanding is that's still something that you can see with ulcerative colitis.
Sure. Not very common, but you can see. So my recommendation and philosophy would be to look at these two diseases with the most common features, the clinical profile first, find out the endoscopic findings, and then look at the histology very carefully, add up all the different points in favor of one disease or the other, and then say that, well, I do have an isolated granuloma. If it is related to a crypt rupture, where there is some mucin and some giant cells around it, that's not the type of granuloma that you see in Crohn's, and it's likely due to ulcerative colitis. But mercifully, we do not see many granulomas in ulcerative colitis. They would be very, very uncommon. The percentage-wise, I can't tell you for sure, but it is less than 1 or 2%. So we're talking about a very rare situation.
And what are your thoughts about focally enhanced gastritis? Sometimes we do biopsies of the stomach, and though it may look normal or may have some mild inflammation, this has been reported as a distinguishing feature of Crohn's disease and can help push you in that direction. Do you agree with that, or how often do you see this?
That's a wonderful question. So, first of all, this is a definite entity in the stomach, the focally enhancing gastritis. The nomenclature isn't ideal, focally enhancing. I would say that it is because most of the chronic gastritis are diffuse gastritis, such as Helicobacter or autoimmune gastritis. These are affecting a large portion of the stomach mucosa. But when you get a focally enhancing gastritis, these are discrete nodules, and they may have these very distinctive Crohn's granulomas, which are epithelioid histiocytes that are located within chronic inflammatory cells. They don't have any foreign body. They don't have any calcification. They don't have any necrosis. They're very, very distinctive Crohn's type granulomas. When these occur, what I typically do, and if it is just an EGD and stomach is the only organ involved, I recommend that the patient undergoes a colonoscopy along with TI examination and, even sampling, random sampling if you don't see anything. But there is a good chance, in fact, a great chance that you will see something in the TI or in the stomach or in the colon. So I have had a few cases where stomach was the first organ where I found focally enhancing gastritis. I alert them of this very strong association with Crohn's. But if everything else is normal, the colon is normal, the TI is normal, there are no radiographic changes of thickening of the wall, the calprotectin is normal, the fecal calprotectin, and there are no other clinical features of Crohn's, I would just observe the patient. I would say that these findings are classically associated with Crohn's, but independent of other organ involvement, calling it Crohn's is not a great idea. Because as you well know, labeling somebody with IBD, that label stays with the patient almost forever.
Would you say that most pathologists out there in the community, based on the second opinions you've done and slides you've reviewed and reports you've seen, can recognize this entity? Because oftentimes we do EGDs and get biopsies, and many of them say gastritis, nonspecific gastritis, H. pylori negative. And oftentimes I don't really know what to do with that result. But do you think that they would, most pathologists would be able to recognize this focally enhanced gastritis and comment on it? Or is this something that we should specifically be asking if there is some suspicion of Crohn's?
So I would look at it in two different ways. Firstly, let me answer the last question. So if you are a gastroenterologist, you already know that the patient has Crohn's in the distal GI tract. Then having a sample of stomach in a concurrent or subsequent EGD and finding gastritis pathologically, it's an easy correlation unless it is a Helicobacter gastritis or some other very clear morphological type of gastritis. But if you do not have that diagnosis clinically available, then I would caution to not overinterpret this. This is not as diagnostic as you would think it is. The granulomas are very subtle. They are less clear than they would be if they are present at all in terminal ileum or in colon. Will most pathologists recognize it? You know, over my decades of work in this field, I have known some brilliant pathologists and many pathologists who are very descriptive but are not that keenly interested in that one particular field. They have different interests. So I think people who are interested in the GI world and they call themselves skilled GI pathologists would not miss this lesion.
Okay. Next, I wanted to talk about Cecal Patch. So oftentimes sometimes in ulcerative colitis, there can be a patch of inflammation near or around the appendiceal orifice in addition to perhaps having some left-sided colitis. And sometimes gastroenterologists will confuse this as a skip lesion and call it Crohn's, when in actuality that's a well-described feature of ulcerative colitis. Do you have any comments on that and what that may mean?
Sure. This is a very dear area for me because what happens is Cecal Patch is actually what you're seeing is a appendiceal tissue showing itself in the appendiceal orifice area. It's a cecal area, but it is basically a portion of the appendiceal mucosa that is being visible to a gastroenterologist or to an endoscopist. Now, every time there is ulcerative colitis, there is always ulcerative appendicitis. Whether the ulcerative colitis is very limited to the distal rectum, in other words, if it's ulcerative proctitis or if it is a left-sided ulcerative colitis, there is always ulcerative appendicitis. And depending on how much of appendix is showing up in the cecum, it may not show up very much and you may not see any cecal patch. But sometimes you have enough of appendiceal mucosa showing up in the cecum. Now, why is the appendix always involved in ulcerative colitis? So there's an embryological reason for that. The appendix and the rectum start as closely approximated portions in embryological development, and the rest of the colon grows in between. So there is a close affinity between appendix and ulcerative colitis. So every time there is a colectomy and you look at the appendix, it will show all the changes of ulcerative colitis as it is seen in the most affected part of the colon. It doesn't cause any clinical symptoms. In other words, it doesn't cause appendicitis, but it is always showing morphological changes. And the recognition of this is so important because, as you rightly said, gastroenterologists, pathologists, they would say, well, I have a skip area because I had colonic involvement, sigmoid colon involvement, descending colon involvement, and then there was nothing in the transverse colon. The ascending colon was normal, and then suddenly I have quote-unquote cecal involvement. So this has to be Crohn's because of the distribution that is patchy.
That's very interesting. There's also this association between having an appendectomy and it being protective or associated with the reduced risk of developing ulcerative colitis and potentially an increased association with developing Crohn's. So I'm wondering if that may be partly due to this embryological association or common embryological origin.
Absolutely. So I think there is the Scandinavian studies are the best, where all the Nordic countries have a common database, and they have seen that in general population, the appendectomy rate is in the tune of 7 or 8%, but in ulcerative colitis, the appendectomy rate is so low, it's less than 1%. So also we see that when you get a colectomy, in cases where there's ulcerative colitis is surgically treated for many reasons or many indications, you will find that appendix is always present. In other words, there hasn't been a prior appendectomy.
Is it, I am recalling a recent consult I have, maybe several months ago, of a young woman with Crohn's who was flaring from Crohn's, had colitis noted on CT, had symptoms, but her appendix was particularly enlarged. And she did have some right lower quadrant pain. The question was, did she have appendicitis on top of a Crohn's flare? Is that, I remember the colorectal surgeon who saw her pretty much said, we never see that. We never see this. Although I've also taken care of patients who've had their appendix removed for this, for potentially acute appendicitis on top of Crohn's. Do you have any comments on that? Is that something that is possible or is common?
Sure. So, the appendiceal involvement in Crohn's is different from the appendiceal involvement in ulcerative colitis. We just discussed that in ulcerative colitis, it's always there, but it doesn't cause any appendicitis because there is just a mucosal involvement. In Crohn's, it is a regional phenomenon. So I would not expect appendiceal involvement in Crohn's unless the very distal part of TI is also involved, or the cecum is also involved. So it is a function of a regional involvement in Crohn's. And what would happen is the acute appendicitis that can occur may be a regular type of appendicitis based on the obstructive component because of the mesenchymal thickening, the stricture formation. So other physiological events that cause the appendicitis, such as a fecalith and other things, are promoted by the connective tissue thickening and mesenchymal involvement in Crohn's. So it does look like acute appendicitis, but in addition to the acute appendicitis, you will see a background of Crohn's appendicitis as well. But it's not just limited to the appendix, but involving the cecum or the TI as well.
Okay. Oftentimes we make IBD patients require surgery, particularly in the context of someone with ulcerative colitis that's not responding to medicines, and then they get a colectomy, or perhaps it's a Crohn's patient with an ileocecal resection. So how would you compare the diagnosis of IBD and distinguishing the subtypes with an actual surgical specimen rather than just these mucosal biopsies? And is that definitive, or still can the diagnosis change?
That's a good question. I think the workup, the best time to make a clear categorization is actually at the very beginning, when you have the presentation and there has been no specific treatment and the patient has a certain profile. That is the best time to make a diagnosis, which is more accurate. Now, once a surgical event has occurred and you have now a bigger specimen to evaluate, more often than not, in fact, in majority of cases, what was expected pre-operatively holds true post-operatively. In other words, if the surgery was done for ulcerative colitis, you usually have a colectomy, total colectomy, and you would see the changes as you have expected them on the basis of clinical story and the prior biopsies. And same goes for Crohn's disease when there is an ileocecal resection. Now, when the diagnosis is altered, many factors could alter the diagnosis. One is the therapeutic intervention alters the way the inflammatory changes look, especially in the mucosa. So you may have some clarity or some clearing of the mucosal inflammation. And so it may begin to look patchy like it would do in Crohn's disease. And it also depends on pathologist who is either very suspicious of the prior diagnosis or is unaware of the prior diagnosis. So I feel that many other factors come into play here, not just that the actual diagnosis has changed. I think the clinical diagnosis is best made in an inaugural situation, and so is the pathological diagnosis. And the course of the disease also needs to be considered. How many flares the patient had, did the course of the disease change? Is this not a pure form of ulcerative colitis or a pure form of Crohn's? Was this ever an indeterminate or an overlapping colitis? So I have many categories. One is, I call this like an overlapping IBD. What does that mean? It means that it's not indeterminate, it is overlapping. And it may overlap synchronously or metachronously. For example, you had a colon that had ulcerative colitis, which was very obvious. Patient had a bloody diarrhea, the colon was contiguously involved, there was loss of vascular pattern, friability in a continuous fashion, going up to a variable length, let's say till the splenic flexure. But the patient ended up having EGD sometime later or at the same time. And in the EGD, there was focally enhancing gastritis. But the terminal ileum was free. There was nothing in the terminal ileum, microscopically, radiographically, or endoscopically. Now, what we have is a situation where there's seemingly ulcerative colitis in the distal colon and potential Crohn's either waiting to happen in the proximal GI tract. So to me, these are overlapping diseases. This is an overlapping IBD. Also, we can have an metachronous ulcerative colitis Crohn's situation. And this is not uncommon. I've had a few cases where it was clearly ulcerative colitis. There was a total colectomy done. The colectomy specimen showed a diffuse ulcerative pancolitis. A pouch was created. The pouch was functioning fine. There was, after 2 or 3 years, there was some pouch dysfunction. And when the pouch was sampled later, 3 to 5 years later, there was Crohn's. So this was a metachronous development of the two diseases. Now, what then is indeterminate colitis? Indeterminate colitis is really inability at the inaugural situation to make the distinction between ulcerative colitis and Crohn's, where you have some fissuring ulcers, some aphthous ulcers, but the distribution looks more like ulcerative colitis, where there's a 35 centimeters of the distal colon involved, but then the appearances are somewhat strange. There is cobblestoning, there's fissuring. And then you say, well, I don't know whether it's Crohn's or ulcerative colitis. That's a clinically indeterminate situation. And then histologically, it is easy to be histologically indeterminate, as you know.
Yeah, I think it is a fear of a lot of patients with ulcerative colitis that after they have surgery that they'll subsequently develop Crohn's, either in the endoleostomy or if a pouch is created. There is some, I've seen some patients at other centers get these they're now doing, like ultrasound, bowel ultrasound in the clinic at certain centers, and actually being able to determine what layers of the bowel are involved by the inflammation, and are sometimes using that as a supplement to determine if it's ulcerative colitis or Crohn's. But speaking about pouches, for the patients listening, a pouch is something created after a colectomy that it's almost like a new rectum out of the small bowel. And so you're reconnected. You don't have a bag on the abdomen, but you have a pouch, and sometimes that can get inflamed. Actually, in the majority of cases, I think over the course of 20 years, at least over 50%, maybe over 70% of patients eventually get some sort of inflammation in that pouch called pouchitis. And sometimes if that doesn't respond to first-line therapies, there's a question, does this person have Crohn's disease of the pouch rather than pouchitis? Do you have any tips for the gastroenterologists out there regarding how to differentiate the two?
Sure. So I would recommend all gastroenterologists who are dealing with this situation to be very disciplined about how they examine the pouch and have a protocol to sample the pouch in an optimal way to figure things out. So people have to be aware of the anatomy of the pouch. You have a little rectal cuff, which is maybe a few millimeters long. Then you have the pouch with a staple line somewhere. And then you have the blind area of the pouch, and then the so-called afferent limb, which connects to the ileum. Now, so in Rush, at least with a few gastroenterologists, we had developed a protocol to always sample these things separately. For example, they would sample the rectal cuff if it was visible, and that may show a pre-existent ulcerative colitis or may just show colonic mucosa with some inflammation that's non-specific. Then they would sample the pouch, proper pouch, avoiding the staple line because that would show some granulation tissue, the staple line. And so they would take from the random area from the pouch. Then they would take from the afferent limb close to the pouch, which would be like a similar situation to what is called as a backwash ileitis. So this is like a backwash pouchitis. So this afferent limb very close to the pouch may show similar inflammation that you will see in the pouch proper. And then they would go a good 10 to 15 centimeters into the afferent limb, examine it, and if they see any kind of erythema or granularity, then they would sample that area, or they would just randomly sample afferent limb away from the pouch. So once you do that, the common type of pouchitis, which is basically an inflammatory, non-specific inflammatory condition, maybe infectious pouchitis, that has a different morphology or histology, where the inflammation is not very patchy, it is diffuse, it's more superficial, in other words, more luminal. It's non-specific. There are no fissures or granulomas or anything, no excessive eosinophils. And that would be a typical pouchitis. And the afferent limb close to the pouch may be normal or maybe slightly inflamed. But as you go into the afferent limb, things are pretty normal. In Crohn's, when Crohn's develops, and sometimes it develops after a true ulcerative colitis and colectomy for ulcerative colitis. This develops maybe 3 to 5 years later. I've had about maybe 5 or 8 cases of this entity. And this is a metachronous development of a different disease, which is Crohn's. And this happens after a good length of time has passed, and the afferent limb away from the pouch also shows the changes that you're seeing in the pouch with maybe fissuring ulcers. So all the hallmarks that you typically see in Crohn's disease in the earlier biopsy in the colon or TI, you would see the same changes in the pouch and in the afferent limb.
Okay, and you did one of the endoscopic ways to also distinguish. I mean, if you see any stricturing in the pouch or fistulas, you have to be a little bit careful about fistulas because if you do see an opening near the where the rectal cuff is, you have to also keep in mind the possibility of a presacral sinus, something more related to surgery rather than Crohn's developing. But those features, also the appearance of the ulcers, can suggest Crohn's. And then there's also ischemia, which has a particular look to it as far as it being in a discrete. Can you have any comments on what to expect with ischemia of the pouch, which can sometimes be confused with Crohn's of the pouch?
Sure. So we have a spectrum of changes. So sometimes the pouch is pretty bland. The evaluation is just a routine evaluation of the pouch, and the sampling is just to confirm that there is nothing happening microscopically, and the changes are minimal. And this is in a vast majority of patients. Then you have the regular type of pouchitis, which is basically an inflammatory/infectious condition that occurs fairly commonly when there is a pouch dysfunction. And depending on the extent of that, you may have mild disease or moderate inflammation. As you mentioned, you can have a surgical complications where there may be a sinus with abscess intramurally, and that can show up as a fissure or a draining abscess, and that is pretty localized. In my opinion, it would look somewhat different from a Crohn's disease, which is pretty patchy, but it is occurring in more than one location. I have also seen cases where there's an allergic pouchitis, where there are tons of eosinophils, and this is an allergic episode. Now, ischemic pouchitis can occur. I've had only a couple of cases of ischemic pouchitis, where the ischemia is a very diagnostic phenomenon histologically, because you have the so-called stromal hyalinization that is so distinctive of ischemia. So that would be, although it is a uncommon and severe condition, it's a very diagnostic condition histologically.
Okay. Yeah, and I think endoscopically that presents as more of a very sharply demarcated area of inflammation that would suggest more ischemia. You did touch on this outside the context of pouchitis. Let's move on from that. But this backwash ileitis, or some people call it ulcerative colitis, associated ileitis, and Crohn's ileitis. So basically inflammation in the ileum and trying to determine if it's due to ulcerative colitis, which can sometimes happen, versus Crohn's disease in addition to colonic involvement. So how do we make that distinction?
So a few things. First of all, for backwash ileitis to happen, you need ulcerative pancolitis. So the ulcerative pancolitis has to affect the entire colon, including the cecum. And often, ulcerative colitis is very loyal to the colonic mucosa, as we talked about earlier, where the colonic glands are the target of inflammation. It stops on a dime at the ileocecal valve and never involves the ileal mucosa. So what is backwash ileitis? Backwash ileitis is almost a chemical phenomenon. It is not really targeting the ileal glands. It's just the content is somehow antigenically active, and you have a kind of a modest amount of inflammatory reaction to that in a very, very limited part of the ileum. So this doesn't extend more than a few centimeters into the very distal part of the ileum. It does not cause any mural or a transmural injury. It is located purely mucosally and doesn't even have the glandular target that the ulcerative colitis does. So there is no comparison between this and what could be a Crohn's disease of the terminal ileum, where the changes are quite distinctive. They include the aphthous ulcerations or a fissuring ulceration, perilymphoid areas involved, patchy inflammation, occasionally granulomas. So all of those things that are unique to Crohn's morphologically are not seen in backwash ileitis. In fact, backwash ileitis is not considered active enough inflammation such that you can use that ileum to create the pouch. So it's not a contraindication to creating the pouch.
And I think endoscopically, a clue that I use is if the inflammation in the TI looks similarly like that superficial type inflammation, that diffuse inflammation you get from ulcerative colitis, if it looks similar within the TI in the setting of pancolitis, it's probably backwash. But if you're seeing discrete ulcerations or aphthous ulcerations, it's more in line with potentially ileal involvement of Crohn's. Also going within that realm of the TI, I wanted to speak about NSAIDs. I have a theory that, and I put out a tweet about this, I think a few years ago, is that I do think, at least in the community, there's probably a substantial amount of people out there walking around with a diagnosis of Crohn's disease that may actually be due to NSAIDs. Because sometimes, if you don't think too deeply about when you see aphthous ulcerations in the TI and just assume it's Crohn's without getting a proper history as far as what medications they're taking, I think there's probably some people out there that are on biologics without actually having Crohn's. It may have been from chronic NSAID use. I've actually seen that in my practice a few times, getting second opinions. Patients carry a diagnosis of ileal Crohn's, and they were taking a lot of NSAIDs at the time of the diagnosis. and then, we have to kind of work backwards to see if they really have it. So I was wondering if you had any comments on that, and is this something that you've seen too?
Sure, absolutely. So if the disease is so limited to 1 or 2 ulcers in the TI, and the NSAID ulcers are very, very classical in the sense that they are shallow, they're superficial, they are broader, and they have they are very discrete. The mucosa around them is quite normal. The mucosa involved, there's a superficial erosion underneath which there is a slight increase in eosinophils. There is no cobblestoning around. And the NSAID ulcers actually stay for a long time. I've had a patient who was misdiagnosed as Crohn's, was an older patient, and had this discrete 1 centimeter ulcer in the terminal ileum, and was on NSAIDs for other reasons. And I thought that this fitted much better with NSAID ulceration in the TI than Crohn's. That diagnosis was accepted by the gastroenterologist. And 5 years later, the gastroenterologist went back. The ulcer was exactly where it was before, exactly on the same fold in the lumen, and looked exactly the same. So these can persist for a very long time. They should be recognized as separate from Crohn's. And you're right, there is a potential for misdiagnosis of Crohn's because of their location in the ileum and because it's an ulceration with some inflammation around it.
So, this reminds me of a case I had recently. A guy with, relatively complex perianal fistulas. He had some cetons in place, and a scope was done by the colorectal surgeon, and there were some very superficial appearing aphthous ulcers in the TI. The rest of the colon was normal. There was no proctitis. Biopsies it was kind of non-specific inflammation that didn't get too much detail on the report. But he was taking a lot of NSAIDs at the time. So, in the setting of having the ulcers didn't look too impressive. They were pretty small, very superficial appearing, just a few aphthous ulcers. So I told him to stop the NSAIDs, and I repeated the colonoscopy 6 months later. The ulcers were still there. It looked pretty much similar. The biopsies did show signs of chronicity. So at that point, with the fistulas, I decided to call it as Crohn's and treat it that way. But it's interesting to hear from you that these ulcers may not disappear in that time frame. So they can persist, it sounds like you said, for years, even after stopping the medicine.
Yeah, I'm not sure about the stopping the medicine part, or, what happens clinically and whether that can be objectively, clarified or measured in the blood, etc. But they can last for years and years and years. But the condition you described, where there was a perianal, and perianal disease is so classical for Crohn's, fistulizing, phenotype of Crohn's, that people think that there was automatically an ileal disease when there is a perianal disease. And so having these superficial, ulcers in the setting of NSAID, I feel that there is probably some component of Crohn's, but there's also NSAID injury on top of that. So I would feel that these situations are more challenging than what they appear.
Sure. And then what are are there other medications that I always think of NSAIDs first, but other medications that can mimic the inflammation of Crohn's or ulcerative colitis that we should be aware of?
I mean, the medications that can cause like a severe colitis or ileitis would be like the immune checkpoint inhibitor therapy, chemotherapy. They can really produce changes that mimic IBD. I think steroids, which are actually given as a therapy for IBD, can in some dosages create ulcerations in the GI tract. Cocaine, recreational drug, can cause changes similar to IBD. But when I see these changes, I try to inquire if I have a solitary ulcer or an ulcer that looks like NSAID. I inquire with the gastroenterologist, and if he or she says that, there's really no history of NSAID, then I still describe it as, pathologically as NSAID-like or NSAID-type ulceration, because it could be by any other medication or other, intake that we don't know about.
Okay. And what are some other mimickers of IBD, actual diseases that can be confused with Crohn's or ulcerative colitis?
Yeah, so the confusion occurs in the initial biopsy. Generally doesn't occur months or years later. So when we have the mimicry, it is usually in the initial biopsies. So I've seen people being called IBD when there is a lingering, the common situation is a lingering infectious colitis, something that doesn't self-limit within a few days, but persists for 2 weeks rather than few days, sometimes persists for 3 weeks. And if I see changes like IBD with a presentation of 3 weeks, I tell them that this does look morphologically like IBD, but the duration is a little too short for IBD. It's 3 weeks, and let's wait and watch. It probably is IBD, but it has to persist for me to be sure that it is, because the lingering infectious colitis can mimic, and this is the most common situation. Other conditions that can mimic, famously, some of the sexually transmitted diseases, famously Lymphogranuloma Venarium. I have myself misdiagnosed it at least once. Lucky for me that it was revealed quite quickly that it is not Crohn's, it is Lymphogranuloma Venarium, because concurrently a chlamydia test was done. Also, there was a history of MSM type history, and also history of travel, particularly to Europe. It's very endemic in Europe. So LGV is the famous misdiagnosis for Crohn's. It looks so much like Crohn's. Occasionally a lymphocytic colitis, microscopic colitis. This is generally, most pathologists can make a good diagnosis of microscopic colitis because the crypts are not so distorted. But occasionally there is cryptitis in these. And when that happens, and this is the first time, and the pathologist is not that experienced, can call it IBD on microscopic colitis or lymphocytic colitis. Divergent colitis really mimics ulcerative colitis. But having this story of diverted colon is so important, that the sampling is from a Hartmann's pouch, and you can then say, so this is definitely divergent colitis, not ulcerative colitis. So these are some of the situations. There are many others, but these are somewhat more common.
Okay. A couple other ones I wanted to touch on. Well, you mentioned Lymphogranuloma Venarium. Would that mainly just be a proctitis, or if you have that, can those type of ulcerations present in other areas of the GI tract?
Yeah, so this it is usually proctosigmoiditis.
Okay.
So it can be proctitis, but it can extend somewhat more proximally. And it has generally some lymphadenitis as well. So in the case I was mentioning earlier, where I had the proctosigmoiditis, had a nice discrete ulcerations, and it looked very much like Crohn's. So I offered that diagnosis, and then, just as a matter of completion, because this was an emergency situation, it was just a sigmoidoscopy. Mm-hmm. The gastroenterologist went and did a full colonoscopy. Mm-hmm. And in the cecum, there was a Kaposi's sarcoma.
Oh, okay.
So, then the plot thickened, and we got the history, which was not available at the time, for travel and Europe and MSM, etc.
Gotcha. Okay. What about for endometriosis? I've seen a couple cases where the diagnosis has been Crohn's has been confused with endometriosis, mainly based on imaging. But if you do, is that easily distinguishable histologically from Crohn's?
Should be, because what endometriosis does is creates like a stricture, localized stricture, because of the expansion of the wall. And so you have a localized type of colitis over a fold, just very similar to what is described as a SCAD, or segmental colitis associated with diverticulosis. Mm-hmm. So morphologically, it shouldn't really be confused with Crohn's. It is localized, though. So if Crohn's, hallmark of Crohn's is patchiness, is localization, then there is a potential for misdiagnosis, but it looks quite different.
Okay. And finally, tuberculosis. What are the distinguishing features? I think particularly in countries that are more endemic with TB, there can be, or at least maybe in the past, there was more confusion between Crohn's and TB, but I think Crohn's is now a worldwide disease and is more on the radar for most pathologists worldwide. But is it easily distinguishable between Crohn's?
Well, as the patient presents, there may be some significant overlap between the symptoms, because you can have fever, low-grade fever, weight loss, involvement of the ileum or ileocecal area. So there are some similarities. There may be mesenteric lymphadenitis. So all of those kind of raise the potential that it could be either Crohn's or tuberculosis. But tuberculosis is quite different looking. It should be different looking endoscopically. It is different looking after resection, if there is a resection. The ulcers described in tuberculosis are actually circular or circumferential and horizontal, versus linear ulcers, fissuring ulcers in Crohn's. And then the similarity is described not just for symptoms, the area affected of the bowel, but also the fact that there are granulomas, or there could be granulomas in both the diseases. Mm-hmm. And hence even the discussion of comparison between the two, or differentiating between the two. The granulomas in tuberculosis are so different from Crohn's. We described the Crohn's granulomas earlier in the discussion. They are very discrete. They are epithelioid histiocytes. They are non-necrotizing. The tubercular granulomas are large. They are confluent. They are necrotizing. They are caseating. They are so different from Crohn's granulomas. So if you go step by step, looking at it clinically, there could be some confusion, but as you go, maybe endoscopically, there may be some similarities. But when you come to microscopic features, they are different, and then resection should be quite different. So at the stage of microscopic and gross pathology, later in the course of the disease, these are two distinctly different diseases.
Great. So I also wanted to move on to C. diff. It's a common scenario we have in the hospital and in the outpatient setting where patients with IBD develop an infection, C. diff, on top of their IBD, and they can have symptoms that mimic a flare. So this is something we pretty much always test for in patients with diarrhea to distinguish it from a flare of IBD. Some GIs have advocated for doing colonoscopy or flexible sigmoidoscopy when we're not sure what's necessarily driving the inflammation. For example, maybe we'll empirically put them on vancomycin or something like that, and maybe they won't get better or not getting the optimal response, or they'll relapse quickly. So doing a scope, does that help distinguish what is the predominant driver of the inflammation? I think most of the time it's both, but if we do a scope and do biopsies from the pathologist's perspective, is that helpful as far as determining what's causing the problem?
It can be helpful, even if you don't see the pseudomembranous patches endoscopically. The feature that distinguishes C. diff colitis histologically is having a certain kind of exudate that is somewhat different morphologically. It has these plumes of exudate that have linearly arranged neutrophils. So they have they call it like a volcano pattern. And not only that, the crypts that are underlying these ulcers or erosions, and you may not see them grossly or endoscopically, is having these crypts that are really distended. The crypts become very different in their shapes. The superficial parts of the crypts distend, and they seem to explode. So they seem to be losing their top, their cap, as it were, or their head. And so this particular formation becomes suspicious, especially when you have a ulcerative colitis that has been managed for a few months or years, and now you have a clinical flare, and there is a possibility that it could be C. diff colitis. As you're waiting for your assays to come out, and as you know, there may be some false positivity and some false negativity in that, depending on the type of assay. So histologically, if you have these features, it strengthens the possibility that it could be C. diff colitis as the cause for the flare.
Okay. Another potential mimicker with ulcerative colitis and Crohn's, particularly involving the rectum, is you'll see this entity called solitary rectal ulcer syndrome, or even maybe something somewhat related, stercoral colitis related to chronic constipation. Sometimes I'll do scopes on patients who are immobile, maybe are from a nursing home, have a lot of health conditions, and are not really moving around, or bedbound, or constipated, and we'll do a colonoscopy for rectal bleeding or something like that, and they'll have a discrete ulceration or just erythema, friability, localized to the distal colon and the rectum, and then the biopsies can be non-specific. So is this something that you have some comments on regarding stercoral ulceration or solitary rectal ulcer syndrome?
Yes, both these entities, I feel, should never, ever be confused with IBD. So we have Let's take stercoral ulcer first. So in stercoral colitis, you have a situation where there is a real motility issues, this story of constipation. There may be fecal impaction. There's a history of prior ER admissions for fecal impaction, maybe. And you have a very distal part of the rectum eroded. And this story is so compelling. And when you look at the microscopy, all you have basically is a mechanical ulcer because of the fecal trauma, the hardened fecal trauma. That's basically an injury to the mucosa because of the fecal material. So different looking from ulcerative colitis or Crohn's.
Okay.
And is very, very limited to the most distal part of the rectum. Of course, depending on how bad the fecal impaction is, you can have it extending proximally. I've had a 90-something-year-old patient with a segment of proctosigmoiditis that was almost 25 centimeters long, and that was a stercoral proctosigmoiditis. And it was only after figuring out that the patient was in nursing home, was disimpacted a few days ago, and now presented with like an overflow diarrhea or diarrhea because of the mucosal injury. Solitary rectal ulcer syndrome is a different entity, of course, and it is basically an eroded mucosal prolapse. So the fundamental finding is a redundancy of the mucosa, a prolapse of the mucosa that eventually undergoes erosion. Again, could be because of the fecal trauma, but it's so localized.
Okay. And then, staying on the topic of rectal inflammation, ulcerative proctitis, it's a limited, by definition, ulcerative proctitis is about up to 18 centimeters from the anal verge inflammation. So a form of ulcerative colitis that's very limited, not associated necessarily with an increased risk of colon cancer, but can be very resistant to treatment. And the inflammation is located in an area that can be very troublesome with regard to symptoms, urgency, mucus, blood in the stool. So do you have any comments on if this is a distinct phenotype of IBD that has its own kind of flavor or characteristics?
Yes, I think so. I think this is a very distinct phenotype of ulcerative colitis, simply because I sometimes suspect this disease purely based on the history. The patients are slightly older. They are in their mid-30s or even mid-40s. They have no diarrhea. They have bright red blood per rectum. The diarrhea is missing because most of the colon is functional and has the, water reclaiming the water resorption is fine. It's only the very distal part of the rectum that is involved. And when you go in and you see this limited ulcerative area, the problem arises when you do a full colonoscopy and you see a cecal patch. People then say, well, I have some cecal inflammation as well. And we discussed that before. So I think that this is a unique phenotype because it is so amenable to topical therapy. As you said, the chances of dysplasia are less simply because the accessibility of evaluation and also the limitedness of the mucosa. So obviously, the more the mucosa is involved, the greater the chance that you will have dysplasia over the period of time. So because this is amenable to topical therapy, there's usually quicker healing, there is less inflammation. In my opinion, I don't really see the ulcerative proctitis repeated that often in surveillance. So I'm assuming that the patients are doing better than they would in a case of regular ulcerative colitis. Also, I find that ulcerative colitis, when it is initial ulcerative colitis is left-sided, there is a good chance that it may kind of progress more proximally and become a pancolitis, or may have microscopic colitis in the areas that look normal, but may be involved microscopically. But ulcerative proctitis is pretty good in not involving anything proximally.
Great. So, now I wanted to move on to the questions from social media. Many people submitted questions through Twitter and my Facebook group. So, sorry to some of the people who submitted some questions that I felt like weren't relevant to the discussion. But the first question is, they're curious to know what your thoughts are on the pathogenesis of IBD. Do you have any theories as far as what could be causing these conditions based on, for over 3 decades, looking at slides of patients with these conditions?
Well, I read the same books that everybody else reads. So the basic 3 pathogenetic pillars of IBD are having a genetic susceptibility to begin with. That's number 1. Number 2 is having some type of antigenic trigger, and this generally is from the contents of the bowel, and so this is like the leaky gut hypothesis, where if you get infectious colitis, then you have the antigens being exposed, and then the third arm of that is having a abnormal immune reaction to it, and that is also predicated on having a genetic susceptibility to creating this abnormal inflammatory reaction. So if you consider these 3 arms together, I find that I like to, when I get a biopsy, I like to look at the clinical profile and see how the patient actually presented. And sometimes the trigger is very, very obvious, like it's actually an infectious trigger. So a patient, who's previously healthy, has a vacation travel history, and then lands with infectious colitis for a few days, responds to medication or hydration, and feels better after a week, and returns back and is fine for 2 or 3 weeks, and then has a tremendous flare of the same symptoms that he or she had before the vacation, or at the initial part of the vacation. And now the changes are ulcerative colitis. So I feel that sometimes this antigenic trigger is very dramatically demonstrated, but sometimes it is basically losing the job or having some type of a very stressful situation. And people know about the brain-gut axis, so I think the mind plays a big role in motility issues in the GI tract. And so I have seen triggers, not regularly, but often enough that I believe in this antigenic trigger.
Some people were specifically asking about the Mycobacterium avium pertuberculosis theory as a cause of Crohn's. I'm not sure if you got a chance to listen to some of my podcasts on that, but any thoughts on that, if that could be responsible for Crohn's or another specific pathogen?
As a practicing pathologist, I would have just an opinion based on histology, and the opinion would be the only reason for bringing tuberculosis into play is the fact that in Crohn's there are granulomas. But other than that, Because the MAP is prevalent everywhere. It's a bovine organism that we all ingest. So does it play a role? I'm not quite sure. I think Crohn's and ulcerative colitis are so closely related that I think if it doesn't play a part in ulcerative colitis, I doubt if it can play a part in Crohn's. But I'm not qualified enough to comment on this with some conviction.
Sure. Okay. And the next question was, are we lumping together multiple related but distinct diseases into two broad categories? And what does the biopsy analysis teach us about this, if anything? So, I mean, there is talk even recently at the Advances in IBD conference about, potentially recategorizing these conditions more based on location rather than just calling them ulcerative colitis or Crohn's. Like, for example, there's some research showing that, colonic Crohn's behaves very differently than ileal Crohn's, and they may be distinct entities. So do you have any comments on that as far as potentially like recategorizing these diseases in a certain way?
Absolutely. I think this is very simplistically handled by everybody in the field. It should be more deliberately and more thoroughly classified. And I believe that pathologists who are interested in this field, this should be only reviewed by the gastrointestinal pathologists who are trained and specialized in this field, because it's such a life-changing event for the patient. And I feel that there should be a template, as there is a template for cancers, where we say, well, we have to document, the type of cancer involvement, the size, all the parameters that the researchers use. We should enroll all of them in a report in a template form. I feel similar things should happen for IBD, not just the distribution of the disease, but the presentation, the family history, if any serology is done, if there is a fecal calprotectin level, if there is a special phenotype. I feel that the perianal Crohn's is a very special phenotype. It's a fistulizing phenotype. I believe that most of the complex perianal diseases of the Crohn's usually have concurrent ileal disease. As you mentioned, the colonic Crohn's, that's the one that is the most commonly interpreted as indeterminate colitis, because you can't really figure out whether it's Crohn's or ulcerative colitis. So I feel the template creation is overdue, where pathologists and clinicians sit together and create a nice template where all these details for not just researchers, but also caretakers take into account all the different aspects of the disease and document them in the pathology report, because that is the ideal place to document them. That would include the radiology, the endoscopy, and all the other findings.
If there is an advantage, I think, of having IBD unclassified or indeterminate colitis, is that sometimes I keep that in the chart, because then they may qualify for the medicines that are both FDA approved for ulcerative colitis and Crohn's, if you don't necessarily call it one way or another. So it may expand the therapeutic options. And as we know, often there is quite a bit of overlap between the medications that are used for both. If you do see somebody with rectal sparing, the rectum is not involved, but let's say they have colitis everywhere else, is that something where you can confidently say, hey, this is not ulcerative colitis, or could it still be within this realm of indeterminate?
That's a great question. So occasionally we find that in a classical ulcerative colitis, the rectum is spared. But my question to whoever says that is, how spared and how long is the sparing? So sometimes there is an embryological rectum that doesn't commence at the dentate line or at the anorectal junction. It commences maybe 3 or 4 centimeters above that region. And so you can potentially have some rectal sparing. I would not expect 10 centimeters of rectum spared in ulcerative colitis, and that, as you said, it would qualify into indeterminate colitis if the colon that is involved proximal to the rectal sparing is contiguous and otherwise looks like ulcerative colitis. I would say this is a slightly atypical manifestation with significant amount of rectal sparing. But 4-5 centimeters of rectal sparing, that's still understandable.
Okay. Yeah, and there has been described a rectal sparing form of colitis associated with PSC, so that may be something to prompt you to get at least liver enzymes or an MRCP to see if that's going on. Okay, and someone asked about liquid biopsies, blood liquid biopsies. I don't know anything about this, but is there any prospect of that helping to diagnose IBD rather than doing colonoscopy?
Well, what is liquid biopsy? Liquid biopsy is basically having a biomarker that is available in the serum and is reflective of or is indicative of what is going on with the disease process. So, can it replace the biopsy? Not currently. And is liquid biopsy a more common thing? It is in the making. It's sure to come. It is something that will happen sooner than later, especially for things that are very hard to determine. For example, when you evaluate colon for dysplasia in ulcerative colitis, most of the dysplasia that can occur is invisible to the gastroenterologist. Hence the need for so many surveillance biopsies to kind of statistically catch it if it is there somewhere. Rather than that, if you had a biomarker that is there in the serum, it would be an easier process. Potentially, things like inflammatory marker, the interleukins that are elevated, you can measure them and figure out the activity. But, currently it is best done with the time-tested way of biopsy evaluation. But it is something that is coming.
For years there's been this IBD serology test, which most gastroenterologists don't use anymore. I mean, it was traditionally used to help differentiate ulcerative colitis from Crohn's, but nowadays it's not really that helpful of a test. The test characteristics are pretty bad, as lots of people with IBD have normal results and lots of people without IBD have abnormal results. There is a test that's been recently put out by Prometheus, this monitor test to assess for healing of the bowel or mucosal healing in Crohn's disease. It's not necessarily widely utilized, but that is out now. And then there is some research going on in trying to prevent IBD by doing blood tests and, as you said, looking for some of these inflammatory markers that are reliably reproduced, even years before the diagnosis of IBD, and potentially coming up with some intervention to prevent it. So those are all things that may be coming up. So I think we'll leave the discussion there. Thanks. I know we initially said 1 hour. It ended up being 2 hours. Sorry for taking an additional hour out of your time. But yeah, anything additional that you wanted to mention? Otherwise, I think we'll wrap it up here.
No, it was my pleasure to talk about these things, and it was your forum. Your podcast forum is such a wonderful place for patients and other physicians and pathologists to visit. So I thank you for making me a part of that.
Great. And what are your plans for the rest of your retirement? Anything exciting coming up?
Yeah, I do some research for some companies that are pharmaceutical companies, but they have tissue that pertains to either GI tract or liver. And who knows, I might get back into part-time diagnostic, pathology, but I don't know for sure for now. I think it would depend on how great I feel physically and how bored I feel due to retirement. But currently, I don't feel bored at all. It's a wonderful life.
Great. So if you ever decide to get back into this, please let me know, because even the people listening here, I get a lot of people who need real second opinions about their slides. So even if you want to do it on a part-time basis or please let me know, because I could definitely send some people your way.
Thank you so much.
Okay. Thank you so much for your time, Dr. Jakate. Hope your retirement goes well.
Thank you very much.